Hello everyone. Welcome back to the Docsaab's Diary. In today's presentation, we are going to discuss vitamin B3, also known as niacin. This is a very important topic because niacin is not only an essential vitamin but also a key player in energy metabolism, cellular signaling, DNA repair, and clinical disease like pellagra. In this presentation, I will take you through its introduction, biochemical functions, metabolism, deficiency syndromes, diagnosis, treatment, toxicity, and therapeutic uses. So let's get started. Vitamin B3 or niacin is a water soluble vitamin that belongs to the B complex group. Historically, it was called the pellagra preventing factor because deficiency of niacin leads to pellagra. Niacin exists in two principal forms, nicotinic acid and niacinamide or nicotinamide. Both forms are converted in the body into active coenzymes that participate in essential biochemical reactions. Although the human body can synthesize some niacin from the amino acid tryptophan, dietary intake remains necessary to meet normal physiological requirements. Now on this slide, we are moving into the real biochemical importance of niacin. The functional cofactors derived from vitamin B3 are the NAD and NADP pool. These include NAD+, NADH, NADP+, and NADPH. These are the biologically active forms that participate in oxidation reduction reactions, energy transfer, and many anabolic and catabolic processes. So, when we talk about niacin deficiency or supplementation, what really matters is how it affects the availability of NAD and NADP inside cells. Let's talk about historical discovery of niacin. From a historical point of view, the discovery of niacin is closely linked to the mystery of pellagra. Pellagra was once a major public health mystery, especially in population with poor diets. In the early 20th century, pellagra ravaged the American South, affecting approximately 2 lakh people annually with a mortality rate of 40%. The prevailing medical consensus held that pellagra was an infectious disease, possibly caused by poor sanitation. Then Joseph Goldberger, a physician in the US Public Health Service, challenged this consensus through a series of bold experiments. In 1914, he observed that staff at orphanages and mental hospitals did not contract the disease despite close contact with patients, suggesting it was not contagious. By introducing fresh food such as eggs, milk, and vegetables into the diets of orphans, he successfully eliminated the disease in those institutions. In 1915, study at Mississippi in prison, he induced pellagra in healthy volunteers by restricting them to this specific corn-based diet. Goldberger's research shifted the focus toward the monotonous southern diet prevalent among the poor, which is consisted largely of corn, salt pork, and molasses. To further prove that pellagra was not infectious, Goldberger and his colleagues held field parties in 1916, where they ingested the skin scabs, blood, and excreta of pellagra patients. None of the participants contracted the disease, effectively debunking the germ theory. Subsequent dietary surveys conducted between 1918 and 1920 confirm a strong correlation between pellagra, poverty, and lack of nutritional variety. While Goldberger proved that a pellagra preventing factor existed in certain foods, he did not live to see the specific nutrient identified. It was not until 1937 that chemist Conrad Illujem at University of Wisconsin isolated niacin from liver extracts. He demonstrated that niacin could cure black tongue, the canine equivalent of pellagra in dogs. This was later confirmed in humans, establishing niacin as the essential anti-pellagra factor. This figure focuses on the synthesis of nicotinamide dinucleotide, meaning the generation of the NAD system from vitamin B3 precursors. Conceptually, there are two important routes to remember: a de novo pathway from tryptophan and salvage pathways from nicotinamide or nicotinic acid. Tryptophan can be converted to quinolinic acid in the kynurenine pathway. QPRT means quinolinate phosphoribosal transferase catalyzes the conversion of quinolinic acid to nicotinic acid mononucleotide. Nicotinic acid mononucleotide is also the product of the reaction of phosphoribosylation of nicotinic acid catalyzed by the NAPRT means nicotinic acid phosphoribosal transferase. Nicotinic acid mononucleotide is then converted to nicotinic acid adenine dinucleotide in a reaction catalyzed by NMNATs, nicotinamide mononucleotide adenylyl transferases. NADSYN, nicotinamide adenine dinucleotide synthesis, catalyze the amidation of nicotinic acid adenine dinucleotide into NAD. Both nicotinamide and nicotinamide riboside are precursors of nicotinamide mononucleotide. The adenylation of nicotinamide mononucleotide catalyzed by NMNATs produce NAD. The image helps visualize how the body converts these precursors into NAD, which then becomes available for energy metabolism, biosynthesis, signaling, and repair. For clinicians, the main takeaway is that deficiency may result not only from poor intake, but also from impaired precursors availability or disrupted metabolism. This slide asks an important question. How do NAD plus and NADP plus work? In simple terms, NAD and NADH are mainly involved in catabolic reactions where the oxidation of macronutrients is coupled with the reduction of NAD plus. NAD plus accepts electrons and becomes reduced in NADH. By contrast, NADP and NADPH are mainly involved in anabolic and protective reactions such as the oxidation of NADPH provides electrons needed for the biosynthesis of macromolecules. NADPH donates electrons and becomes oxidized NADP+. So one useful way to remember this is NAD helps break down fuel while NADPH helps build and protect the cell. Now we move into the biochemical functions and metabolic roles of niacin. Through NAD-dependent reactions, vitamin B3 is essential in redox reactions and energy metabolism. Over 400 enzymes require NAD plus and NADP plus as coenzymes. In normal metabolism, NAD participates in glycolysis, especially at the glyceraldehyde 3-phosphate dehydrogenase step, in the pyruvate dehydrogenase complex, at the PDH complex, in the citric acid cycle, at the isocitrate dehydrogenase, alpha ketoglutarate dehydrogenase, and malate dehydrogenase step, and in oxidative phosphorylation, particularly at complex 1 such as NADH dehydrogenase. It also supports fatty acid oxidation at the all acyl CoA dehydrogenase steps and alcohol metabolism through dehydrogenase systems. So clinically and biochemically, niacin is deeply embedded in energy generation. When niacin is deficient, tissues with high metabolic demand are often the first to show dysfunction. In addition to catabolic metabolism, NADPH is essential for anabolic reactions. It supports fatty acid synthesis, cholesterol and steroid hormone synthesis, deoxyribonucleotide synthesis for DNA precursors, and glutathione regeneration, which is critical for antioxidant defense. An important biochemical detail is that niacin can be formed from dietary tryptophan. Approximately 60 mg of tryptophan can generate 1 mg of niacin equivalent through kynurenine pathway, and this conversion requires vitamin B6 as a cofactor. NAD plus also has an important signaling role. It serves as a substrate for PARPs in DNA repair and stress responses, sirtuins in aging and longevity pathways, and enzymes such as CD38 and CD157 involved in calcium signaling and ADP ribocyclases for neurotransmission and insulin secretion. Let's talk about absorption, metabolism, distribution, and excretion of niacin. Niacin is absorbed from the small intestine via sodium-dependent facilitated diffusion at low concentration and passive diffusion at higher concentrations. Both nicotinic acid and nicotinamide are well absorbed. It then undergoes first-pass metabolism in the liver. There are two major hepatic metabolic pathways. First, conjugation with glycine forms nicotinic uric acid, and this pathway handles high quantities but causes flushing. Second, amidation forms nicotinamide and further converted to NAD+. These pathways easily overwhelm and produces hepatotoxic metabolites. The vitamin and its metabolites are distributed systemically, 20% bound to plasma proteins and distributed mainly to liver, kidney and adipose tissues, and eventually 60 to 76% eliminated via urine, up to 12% excreted as unchanged drug, and main urinary metabolite is N'-methyl nicotinamide, N'-methyl 2-pyridone 5-carboxamide. So from a pharmacological perspective, niacin behaves like a vitamin at nutritional doses, but more like a drug at high therapeutic doses. Now let's look at the recommended daily allowances for niacin. Requirements increase with age and differ by sex and physiological state. Infants require between 2 and 4 mg, Children 1 to 3 years require 6 mg niacin equivalents. 4 to 8 years require 8 mg niacin equivalents. 9 to 13 years require 12 mg niacin equivalents. Adult male requires 16 milligrams. Adult females 14 milligrams, while needs rise during pregnancy to 18 milligrams and during lactation to 17 milligrams. For exams and clinical reasoning, it is important to remember that nutritional requirements are usually expressed as niacin equivalents because the body can derive niacin from tryptophan as well as direct dietary intake. Now let's look at the food sources. Niacin is widely distributed in food. Animal sources include chicken breast, turkey, tuna, salmon, beef liver, pork, eggs, and milk. Plant sources include peanuts, peanut butter, mushrooms, brown rice, legumes, whole grains, avocado, and sunflower seeds. Other sources include fortified cereals, fortified bread, yeast extract, coffee, and tea. From a public health perspective, deficiency is more likely to result from diet quality, malabsorption, alcoholism, or metabolic diversion, rather than complete absence of niacin in the modern food supply. Now we come to the most important clinical disease associated with vitamin B3 deficiency, and that is pellagra. The word comes from the Italian roots for rough skin, reflecting its prominent dermatologic features. Pellagra is traditionally remembered by the 4Ds: dermatitis, diarrhea, dementia, and death. However, early symptoms may be much less specific, such as fatigue, poor appetite, weight loss, generalized weakness, irritability, sleep disturbance, and vague abdominal complaints. So, clinically, pellagra should be suspected before the full syndrome appears, especially in at risk patients. This slide focuses on the dermatologic manifestation of pellagra. The rash typically bilaterally symmetrical and appears in sun-exposed areas. It is often erythematous, burning, scaly, and later hyperpigmented. The classic pattern includes the castle necklace around the neck, pellagrous glow lesions over the dorsum of the hands, boot-shaped lesions on the feet and lower legs, and butterfly distribution over the face. The clinical images here are useful because they show how pellagra dermatitis is not random. It has a characteristic photosensitive and symmetrical distribution, which helps distinguish it from other dermatoses. Beyond the skin, pellagra also affects mucous membranes, the gastrointestinal tract, and the nervous system. Patient may develop glossitis, bright red, painful tongue, stomatitis, inflamed oral mucosa, cheilosis, fissuring at the mouth corners, increased salivation, and edema. Gastrointestinal symptoms include burning sensation in the pharynx and esophagus, abdominal discomfort, distension, nausea, vomiting, and diarrhea, which may even be bloody. Neurologically, early symptoms include anxiety, poor concentration, fatigue, depression, and headache. Advanced disease may progress to confusion, disorientation, memory loss, and confabulation. And severe untreated deficiency may culminate in psychosis, delirium, dementia, and encephalopathy. If untreated, severe cases can eventually be fatal within 4 to 5 years. Let's talk about genetic disorders related to niacin. One important genetic disorder related to niacin deficiency is Hartnup disease. This is an autosomal recessive disorder caused by mutation in the SLC6A19 gene, leading to a defect in neutral amino acid transporter B081. As a result, neutral amino acids, including tryptophan, are poorly absorbed in the intestine and lost in the urine. Because tryptophan is a precursor for niacin synthesis, this can produce a secondary niacin deficiency state. Clinically, patient may show a photosensitive pellagra-like rash, cerebellar ataxia, tremors, mood and psychiatric symptoms, neutral amino aciduria which serve as the important diagnostic marker, and sometimes short stature and developmental delay. Another important disorder is carcinoid syndrome. In this condition, tumor metabolism diverts tryptophan towards serotonin production, reducing its availability for niacin synthesis and thereby predisposing to pellagra. There is also rare niacin responsive inborn errors involving defects in NAD biosynthesis, such as problems with NAD synthetase or related enzymes. The clinical message is that pellagra is not always due to simple malnutrition. Sometimes it reflects altered metabolism or genetic disease, and these cases may require targeted recognition and high dose supplementation. The major risk factors for niacin deficiency can be grouped systematically. Dietary risks include poverty, malnutrition, anorexia nervosa, and maize-based diets that are not alkalized. Medical risks include chronic diarrhea, cirrhosis, alcohol use disorder, and malabsorption syndromes. Genetic risks include heart nerve disease and carcinoid syndrome. Drug-related causes include isoniazid, pyrazinamide, 5-fluorouracil, and 6-mercaptopurine. While metabolic stressors include hyperthyroidism and prolonged febrile illness. So, when evaluating suspected pellagra, it is important to think beyond diet alone. Now, let's talk about diagnostic assessment methods. Diagnosis of niacin deficiency is often primarily clinical. A strong clue is the characteristic pattern of dermatitis together with gastrointestinal or neuropsychiatric symptoms, particularly in the right risk setting. In many cases, therapeutic response to niacin helps confirm diagnosis. Functional assessment may include erythrocyte NAD concentration, which is a sensitive marker, and plasma homocysteine, which may be elevated due to impaired 1-carbon metabolism. Laboratory clues include low urinary N-methylnicotinamide, reduced erythrocyte NAD, reduced plasma tryptophan, abnormal niacin metabolite patterns, and low NMN to creatinine ratio. Now let's talk about treatment. Treatment of pellagra is usually highly effective when recognized early. For acute pellagra, the preferred therapy is nicotinamide, typically 250 to 500 milligrams orally, 3 to 4 times daily for 3 to 4 weeks. Nicotinamide is preferred over nicotinic acid because it avoids the classic flushing reaction. Management should also include a balanced diet, adequate protein, and replacement of other B vitamins such as riboflavin and pyridoxine. The clinical response can be dramatic, with skin lesions beginning to improve within 48 hours. Patients should also be advised on sun protection while the skin heals and on alcohol abstinence from when relevant. And WHO recommendation of 300 milligrams daily nicotinamide in divided doses for 3 to 4 weeks. In heart nerve disease, management includes a high protein diet, usually around 1 to 1.5 grams per kilogram per day, plus nicotinamide 100 to 300 milligrams daily with higher doses during symptomatic episodes. Ongoing monitoring of urinary neutral amino acids may be useful. The prophylactic supplementation in high-risk groups such as patients on isoniazid or those with malabsorption, where 50 to 100 milligrams of nicotinamide daily may be appropriate. So treatment is not only reactive, it can also be preventive in selected populations. Niacin also has a therapeutic uses beyond treating deficiency. Historically, it was used in dyslipidemia treatment because it can raise HDL cholesterol obtained at doses of 1000 to 3000 milligrams per day. However, an important question from 2024 NIH study suggesting that excess niacin may produce a metabolite called 4-PY that could promote vascular inflammation and increase cardiovascular disease risk. Nicotinamide also has a role in skin cancer prevention, with 500 milligrams twice daily associated with reduced new non-melanoma skin cancers. Other investigational uses include Friedreich ataxia with high doses of niacin, HIV-related metabolic complications, schizophrenia, and cancer cachexia. The key message is that niacin has moved from being seen as just a vitamin to being a considered molecule with broader therapeutic implications. With therapeutic dosing comes the issue of adverse effects. The classic reaction is niacin flush, a prostaglandin mediated vasodilatory response causing redness, warmth, and itching, mainly with nicotinic acid. More serious toxicity includes hepatotoxicity, which can progress from elevated transaminases to jaundice and liver failure. Other adverse effects include nausea, vomiting, diarrhea, epigastric pain, worsening peptic ulcer disease, hyperglycemia, hyperuricemia, hypotension, palpitation, arrhythmias, retinal edema, toxic amblyopia, cystoid macular edema, thrombocytopenia, and myopathy or rhabdomyolysis, especially when combined with statins. So clinically, niacin may be beneficial, but it is certainly not harmless at pharmacological doses. Drug interactions are also very important. Combining niacin with statins increases the risk of myopathy and rhabdomyolysis, especially at niacin more than 1 gram per day. Bile acid sequestrants such as cholestyramine can reduce niacin absorption, so their administration should be separated by several hours. Isoniazid can deplete niacin and contribute to pellagra. Niacin can potentiate hypotension with antihypertensives, increase bleeding risk with warfarin due to platelet effects, and worsen blood sugar control in patients taking anti-diabetic medications. Drugs like azathioprine, 6-mercaptopurine, levodopa, and carbidopa may interfere with tryptophan-niacin pathway, while alcohol worsen NAD depletion and niacin flushing. This is an important because it connects nutritional biochemistry directly to clinical pharmacology. Finally, let's discuss niacin toxicity or overdose. Toxicity is generally seen at doses above 3 grams per day, with sustained release preparations being the most dangerous. The characteristics liver injury pattern includes centrilobular necrosis and microvesicular steatosis, and laboratory abnormalities may include elevated AST and ALT, elevated PT and INR, increased ammonia, and bilirubin that may initially remain normal. Severe complications include liver failure, multiple organ failure, or maybe death. Management begins with immediate cessation of niacin, followed by ABC stabilization, intravenous crystalloids for hypotension, dextrose for hypoglycemia, and acetylcysteine in severe hepatotoxicity, blood products if there is coagulopathy, and liver transplant evolution in fulminant failure. Antiprostaglandin agents such as aspirin or ketorolac may be help with flushing. The main takeaway is that high dose niacin should be treated with same seriousness as any potentially hepatotoxic drug. To conclude, vitamin B3 is far more than a simple dietary micronutrient. Through its role in NAD and NADP biology, it is essential for energy metabolism, biosynthesis, DNA repair, antioxidant defense, and cellular signaling. Clinically, deficiency present as pellagra, but niacin is also relevant in genetics, pharmacology, dermatology, internal medicine, and toxicology. Thank you very much for your attention. I appreciate your time and I welcome your feedback and discussion. And if you enjoyed this presentation, don't forget to like, share, and subscribe to the Docsaab's Diary for more medical presentation and educational content. Also, let me know in the comments which vitamin or metabolic topic you like me to cover next. Thank you.